So we're here at the EVTM Symposium. I'm here with Professor Todd Rasmussen, with Professor in Surgery, a series of deployments in Iraq and Afghanistan, and Professor Kenneth Bofford, the course director and editor of the DSTC manual. Thank you for participating in this interview.
Sure.
So, over the past day or so here at the EVTM Symposium, we've been discussing endovascular techniques in trauma management. But EVTM stands for much more than just the endovascular techniques. It stands for, I'm thinking about the multidisciplinary approach to the trauma patient. Todd, how do you see that the EVTM multidisciplinary approach is implemented in the military setting?
What well, as a military surgeon, what I can see and in the EVTM format and the individuals that are here today and had gathered here 18 months ago is a real sense of teamwork. And as a military physician and as a military, we train together. We train as a team, and I see a lot of that same camaraderie here among the disciplines that are here. In approaching the patient, the severely injured patient in shock. It's interesting here, the other aspect of teamwork is international. It's not just multidisciplinary among different disciplines of providers, but it's individuals from around the country and around the world, which is also very impressive.
And you have different, obviously different specialities in these settings. What do you find? Because we're talking a lot about with other people about the, we have interventional radiologists, vascular surgeons, trauma surgeons, general surgeons. Which different specialities do you think are key in this multidisciplinary approach?
Well, I think you've mentioned many of them. I do know from my experience in the deployed setting that we, again, back to the team concept, we may not always have in a given deployed setting one or two certain disciplines of the team that you mentioned. So we rely on each other to best assess and then manage the severely shocked patient. And I think whether that is a general surgeon, an interventional radiologist, an intensivist, or a vascular surgeon, I think it depends, for us, it depends upon the time and the deployed setting and who's available. But that's why it's important to practice as a team.
Absolutely.
So that we don't have any gaps in this aspect of care.
And are these different specialities, are they specifically trained in endovascular resuscitation for their deployment?
I think many of them are. Certainly interventional radiology, vascular surgery, endovascular surgery, and some of our intensivists are. And increasingly, I think our general and trauma surgery colleagues are embracing a basic endo skill set. We have some courses that we offer for basic endovascular skills for trauma, the BEST course that we offer to individuals before they deploy to refamiliarize them with vascular access and basic resuscitative maneuvers using catheters and wires. And so it's a mix, and I think, again, that's why we try to train in a diverse, multidisciplinary fashion so that we can cover the requirement regardless of exactly who's, which discipline is able to go at a given time.
And in which way do you see that, either from your own experience or have you heard from others, how endovascular resuscitation or endovascular techniques are performed in these military settings? Do they differ in any way?
Well, I think they're new. Many of these, well, they're new again. I mean, many of these technologies have been around for decades, as you know, but I think their application in current theaters of war is relatively new, and some of the devices are new. And so I think that their use right now is still, I think, we're becoming more familiar with them in which patients to use them in, which operational scenario, and I think there's good promise for them for sure. But I would say that the endo techniques in the deployed setting are still relatively new, and we're learning.
So it's probably the way that they're used is very similar to what we're used to in hospitals back home.
Yes, yeah, and probably perhaps even more to a restricted degree because of the austere nature of some of our operational scenarios. We don't have luxury to inventory, for example,
of course.
An endovascular inventory in all of our deployed settings as one example. And so we still rely in the deployed setting primarily on open, traditional hemorrhage control and resuscitation techniques. However, for certain injury patterns, in certain situations, just like in the civilian setting, we see endovascular techniques as playing an important role. And so we'll continue to grow that with new technologies and experience in our providers, for sure, I believe.
That's great.
Yeah.
Dr. Bufford, how, this modern surgery requires obviously infrastructure and resources, especially endovascular surgery. You mentioned yesterday in one of the discussions that the cost of, for example, a Roboa catheter can be similar to what a nurse's salary in South Africa, where you're from. How do we implement these expensive techniques in, for example, developing countries? These techniques are they possible in these countries, or is it just for the rich and wealthy?
I think that there's a dichotomy for lots of reasons. Some of what Todd has been saying, when a military deploys, it kind of knows what it's going to get. That's why it's deploying, and they anticipate the sort of injuries they're going to get. When you're talking about Western Europe and fully developed countries, the reality is people are so specialized that team concept very rarely exists anymore. Mm-hmm. So each individual works within their zone of comfort, which is increasingly small. The psychiatrists call it the darkness beyond the campfire. They want to be next to the campfire. And the end result is they become very apprehensive. So courses like this, looking at new techniques, also look at providing a broader educational, thinking outside of the box much more than most other things. With regard to first and third world, first and developing cultures, you've got a logistics issue, getting the resources to where it's needed. Because if you have a small rural hospital, the costs of keeping the necessary equipment for Roboa is just prohibitive. That would probably apply even in the US. There would not be in rural Kansas in the little hospital enough depth of equipment to do things safely. So there's always going to be a place for the old-fashioned stuff. I think what is also clear is that as the techniques become more refined, more popular, the costs often do go down. So what is not obtainable in an initial environment, and I think we're still in that. I mean, Roboa is still a tiny fraction of the procedures that are done worldwide. But as it becomes more popular, as its focus becomes clearer, because it's being used by a number of individuals who are beyond the campfire. So they're not quite sure whether they should be using this, but let's try it. I think the cost will come down. I think it will become far more readily available. It's just one more very good refined technique in the pretty big armament of what's used to treat trauma.
Yeah, you touched a little bit on this, that different courses should start incorporating these techniques, but also that the open surgery obviously still plays a major part in these countries. Apart from developing countries, and I'm thinking just in courses in general, you mean you're the editor of the DSTC manual. You mentioned yesterday as well how now in the next edition endovascular techniques will be a part of the DSTC course. In which way will these techniques, do you believe, have an impact in this course in the modern, the Western world?
The Western world is in many situations outside of the US and places like South Africa trauma naive. They don't see enough trauma to really be comfortable practiced at it. And the DSTC course, which I was involved in development, is now the world's second largest surgical course and the most advanced open surgical course, because most physicians within the fully developed countries, Western Europe and so on, everything is done scopically. And so when you're faced with a situation of maybe this is the first time this year or ever you've actually been inside a tummy or a chest, oh my goodness, what am I going to do next? And if I can do something like getting at it using techniques that I'm already familiar with, I'm an interventional radiologist or whatever, and can deal with it as well or better, and that's the discussion. So the course like a DSTC, which is aimed at people who are out of their zone of comfort, suddenly faced with doing things, Reboa is very much part of what is available. We need to tell the participants what it's good for, what it's not good for, how to do it, and maybe when not to do it.
Because I can imagine that, for example, your residents in South Africa, maybe a first or second year resident is very comfortable with opening up the chest and doing putting a clamp on the aorta. For example, myself or even my colleagues here in Sweden, we don't see very much trauma, and to do something like that is a major step for us. And we're not at all, we will see these types of traumas maybe a few times a year, whereas you have them, you're on a daily basis seeing these.
It's an interesting comment, because we've seen very good papers, for example, showing times taken for the different techniques. But what they don't take into account, and what I teach to our more junior people, is the most difficult thoracotomy you will ever do is your first one. Not because of the technical side, but because of your mental jump that you've got to give. And if Reboa provides you with confidence to do something earlier and does it as well, then there's a big advantage to it.
Todd, apart from the military and conflict zones, in which way do you believe that the EVTM concept and endovascular techniques can play a part in other austere environments? I'm thinking disaster zones, natural catastrophes.
Well, I think again, we go back to the multidisciplinary teamwork approach that is on display here at the EVTM meetings, and that concept, I think, serves the austere setting very well. It serves those who are being treated in that situation very well, whether that's from an armed conflict or in the setting of a natural disaster or man-made disaster. I think it's that multidisciplinary effort that's patient-focused, that is, I think, in some ways freed from some of the traditional boundaries that we face in subspecialized civilian care and our routine practices. I think the austere situation, whether it's from an armed conflict or care following a natural disaster, a lot of those barriers can be freed, I think, because of the urgency of the mission. And I think we focus more on the patient than our own disciplinary boundaries, traditional dogma. And so I think the lessons that we are discussing here at EVTM and the whole concept of EVTM serves that very well. And frankly, I think my observation is it's part of the reason EVTM has been so successful is that it has taken a topic that's somewhat at the margins of all of our traditional disciplines, that being endovascular hemorrhage control and resuscitation, management of that trauma patient. If you think about it, that's a small piece of many different disciplines, but it's somewhat at the margin of radiology, somewhat at the margin of traditional vascular surgery. It's a little bit at the margin of general surgery and so forth. And so I think what EVTM has done is coalesced in one setting for the meeting, and then a journal, and then this I think as an overall concept has really provided a venue for that topic, which again is otherwise somewhat at the margin of all of these other traditional disciplines. And certainly for us in the military, there's not a more important topic than hemorrhage control, whether it's using traditional open techniques or learning and availing ourselves and our service members to new emerging technologies.
Yeah. It's like we said yesterday during the meeting that trauma surgery is what kills first is bleeding. So trauma surgery is basically becoming vascular surgery to some extent, and therefore vascular surgery is becoming endovascular, so trauma is becoming endovascular in one way.
Yeah.
I think that's true. The caveat, obviously, is what you have here is a group of enthusiasts. And enthusiasts, by their nature, adopt things and do it well. There is the gap between the enthusiasts, and there's no free lunches in this. So there are complications from any technique. This is one of them. And done badly, this has got some potential problems. So part of the role of what we're doing here is just, and I agree with Todd, the military is unique because you have to form a team. It's part of what the military is. And yet most civilian environments, and I include Sweden in that, you have people talking at each other and disciplines competing probably for grants.
Yeah. Absolutely.
Remarking fairly bitterly that they cannot get funding for their particular project.
Yeah, or competing for patients, you know,
Indeed.
and reimbursement.
And so, and so a meeting like this has got two functions. One is to spread the word of what can be done, and again, to spread the word that if you embark on anything, be aware of the risks and try and anticipate them.
And that was my next question was, what do you think? What are the risks with endovascular resuscitation going forward? What do you both think we can learn from the past? What mines should we not tread on?
Well, I think I think one of the observations, and we've talked about this over the last day or two with individuals and as a group. Is that as technology improves, and Professor Boffard mentioned this, as technology improves and our familiarity with technology improves, not only does cost often go down, but our ability to do it well with lower morbidity and mortality also increases. We improve because the devices get better. Not always, but certainly, for example, we've seen this with the management of blunt aortic injury, which a decade and a half ago was all done open through a thoracotomy, and we watched the introduction of thoracic stent grafts, and initially our results in managing blunt aortic injury with endovascular techniques was a little rocky because the technology wasn't really made for trauma.
That's right. Technology was for old people.
That's right, for age-related aneurysms. But as that technology improved, got smaller, we became more proficient with it. Over a decade or a decade and a half, now the risk of complications from in this one instance, right? It's one injury pattern, so it doesn't apply to all of trauma. But I think it's a case study to your question of how technology evolves, and we can get better with the technology. The other thing that's come out of that is we know now more about the pathophysiology of aortic injury. We know the different types. And I see that there are certain areas of EVTM and endovascular techniques for certain injury patterns, not all of them, but for certain injury patterns in clinical scenarios, endovascular techniques have that potential.
10 or 20 years ago, did we need a law against texting on your cell phone in a motor car?
Yeah.
There's a whole new bunch of motor crashes that are being caused by technology not intended for that purpose. And so much of what we've been talking about now, and I'm being slightly facetious, but the reality is so much of what we're talking about now is great, but it does need, partly because of its cost, but partly also because it creates new problems that we weren't anticipating. It's got to mature, and it's fora like this that allows that maturation.
And I think it's the EVTM form and concept that put that front and center.
Yep.
When I talk about this topic being at the margins of these other disciplines, one can go to a very general surgery centric organization or meeting, and this will be maybe at the margin. There'll be one or two talks, 3 talks, and some discussion, but the bulk of that is around core general surgery topics. One can go to an interventional radiology conference, and maybe there'll be some small sliver of that meeting that will address trauma and shock and so forth and so on. And because of that, that's when I say it's relatively marginalized. But here at EVTM, and I think the EVTM concept as a whole, the journal and sort of the movement, it puts that topic front and center. and allows, at least in one venue and one concept, that to be the focus. And I think that's important, and certainly from the military standpoint, and I suspect the civilian standpoint as well, it's useful.
And what do you think is, for the conference, the EVTM conference and these gatherings, what do you think is the next step? How are we going to take this even further forward? I'm not thinking the specific techniques, is more just the concept or the conference as a whole.
Yeah,
I think it's going to the technique's going to become more accessible. It's going to become more mainstream. That changes the way the conference, and it may well be that this conference subsequently becomes part of something else. So it will mature. I mean, there's a great initiative from here.
yeah.
See where it goes.
Yeah, I think it'll be. I don't know exactly what the next steps are, but I think it'll be. Because of the nature of endovascular technologies, and we've seen this for age-related cardiac disease, peripheral arterial disease, and so forth. That if the innovation continues in the area of shock, hemorrhage control, resuscitation in the endovascular realm, EVTM is going to be there to be the venue in which that can be discussed and vetted. You mentioned what are some of the no-go areas, and I think that's important too. We although this group is largely enthusiasts, at each session there is debated and highlighted areas that this technology is not ready for. It's not able to at this time provide benefits. So I think vetting is another important role of this. Yes. And as the technology inevitably, as it inevitably will, advances, EVTM will be there, I think, to help vet that technology and shape it.
Yeah. Okay, well, I'd like to thank you both very much for participating in this interview. So we've just heard from two of the most experienced surgeons here, Professor Bofford and Professor Rasmussen, and their ideas of how EVTM is applied in less than ideal environments.